Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello and welcome. Today's presentation, Advanced Treatments for Knee Pain, is presented by Dr. John Dearborn. Dr. Dearborn is an orthopedic surgeon with Dearborn & Associates. He is also the medical co-director of the Institute for Joint Restoration located in Fremont, California. Dr. Dearborn received his medical degree from the University of California, San Francisco, where he also completed his residency. Without further ado, please welcome Dr. John Dearborn.
Good afternoon. My presentation today is entitled Advanced Treatments for Knee Pain. And like any presentation, we need to have goals. So by the end of our time together, I hope that you will have learned the various causes of knee pain, that you'll have some understanding of the non-surgical treatment options for mild, moderate, and severe osteoarthritis. And you will have been exposed to state-of-the-art surgical options. A little bit about me. I'm an arthritis surgeon, which means that I take care of patients with arthritic hips and knees. I've been in practice for 24 years, and in 1999, I founded the largest joint replacement program in Northern California, where we evaluate hundreds of patients with knee and hip complaints every month. We treat adults of all ages, shapes, and sizes, and we provide the full range of treatments. I personally perform over 900 procedures annually. Knee pain, of course, has many causes, and we won't cover them all, especially the acute injuries, but we've got acute injuries, which is going to include sprains and strains, torn ligaments or cartilage or fractures, overuse injuries, which are typically going to be tendinitis, synovitis, and patellofemoral pain, which could come up during the Q&A. And there are medical conditions which can cause knee pain as well, including arthritis and infection. Along with the many causes, of course, there are many treatments. And most causes of knee pain can be managed with self-care measures such as rest, elevation, compression, ice or heat, anti-inflammatory medications like Aleve or Advil. Occasionally, physical therapy is necessary. Knee braces can be used as well. And we will talk about injections and the surgical repair later in the talk today. In order to understand the various causes of knee pain, it's important to understand the anatomy. There are three bones that make up the knee joint: the femur, the tibia, and the patella. Viewed arthroscopically, we see the femur on the right. This is the medial femoral condyle, and this is the tibial plateau, and the medial meniscus here with a large tear right through the center. We're going to move on and spend time on arthritis, which is really the focus for today. We'll be covering crystal deposition diseases, which are truly a type of arthritis. They're really an inflammatory arthritis. We'll be covering the common inflammatory arthritis, rheumatoid arthritis, as well as some others. And then we'll be concluding with our time with osteoarthritis, which is wear and tear. The first of the crystal deposition diseases is gout. Gout is caused by uric acid crystals being deposited inside the joint. Typically, patients suffer attacks of severe pain, which can be sudden, and swelling and redness of joints. Often these will occur at night. The big toe, of course, is the most common site that we all know about, and these joints are so painful that even the weight of a sheet over the top of the foot is extremely painful. The knee is commonly hit by gout as well. It can hit the hands, it can hit the ankles, it can hit the elbows. The symptoms can sometimes linger for days to weeks, and if untreated, gout can cause joint and tendon damage. If you have a hot and swollen joint, you might consider calling your physician because an infected joint may present the same way. Gout is caused by high levels of uric acid in the blood. Uric acid is produced by breaking down of purines, and purines are chemicals found in certain foods like steak and fatty meats and seafood, beer, etc. And if you consume too many purines, or if your body has impaired clearance of uric acid, you're at increased risk for developing gout. There are several other risk factors that I have listed here, which include male sex, unfortunately. The treatment for gout is typically anti-inflammatory medications, including a drug called colchicine, which you can overdose on it fairly easily, so you need to do it low dose and under a physician's supervision. The mainstay of gout treatment is prevention, which is basically avoiding all of those states where you're at more risk. So staying hydrated, limiting sweet beverages, limiting alcohol, especially beer in men. Sorry, guys. Getting your protein from low-fat dairy sources is actually protective. Limiting the intake of meat, fish, and poultry, maintaining healthy body weight, avoiding fasting or starvation diets, which can actually increase your serum uric acid level. And a drug called allopurinol, which is a purine analog that is used to treat the disorder or prevent the disorder from occurring. Pseudogout is the other crystal deposition disease and is caused by calcium pyrophosphate crystals being deposited in the joints. The presentation can be similar to gout, although usually less acute. The joints are less swollen and less red. The knee is the most common site. The cause of the deposition of calcium pyrophosphate is not known, but we know that the risk increases with age, and it's commonly seen on Xrays of older folks who don't have symptoms. And on this picture, I've got calcification of the lateral and medial meniscus that you can see, which is the typical appearance of calcium pyrophosphate deposition, or CPPD, on an X-ray. The contributors are thought to be trauma, excess calcium or iron in the system as well. The diagnosis of pseudogout is confirmed by joint aspiration. The crystals can actually be seen under a microscope with polarized light. And the treatment is primarily symptom management, the use of anti-inflammatories, colchicine, like I mentioned for gout, and steroid injections. We'll move on to inflammatory arthritis, and all of the various types represent an overactivity of the immune system. Essentially, your own body tissues are seen as harmful germs or pathogens, and as a result, there's inflammation of the tissues in and around the joints. Inflammatory arthritis can affect several joints at the same time and can affect people of all ages as early as it's more common in women. The symptoms are typically morning joint pain or stiffness, or pain after sitting for a long time in one position. The joints can be swollen, red, and or warm, and the inflammation can occur in other areas of the body as well, such as the skin, lungs, and heart. Often the symptoms will flare, and then they'll settle down, and you'll go into a remission period. The major types of inflammatory arthritis are rheumatoid, which most of you have heard of, I'm sure, ankylosing spondylitis, lupus, psoriatic arthritis, and Lyme disease is actually inflammatory arthritis. In comparison with osteoarthritis, in which the joint is damaged due to wear and tear, the osteoarthritis is going to take longer to develop because it takes wear to produce it, and so the osteoarthritis patients are going to present later in life, usually after age 50. The diagnosis of inflammatory arthritis is based primarily on blood tests to detect certain antibodies, especially for rheumatoid arthritis. If we biopsy the synovial lining and a pathologist looks at it under a microscope, they can often be very helpful in making the diagnosis. And diagnosing this early can allow treatment and preservation of the affected joints, so it's important to make the diagnosis early. The treatment is focused on anti-inflammatory medications and immunosuppressive agents to suppress the overactive immune system. Late in the disease course, joint replacement surgery can be very effective. We're going to move on to osteoarthritis now. So I'll give you the take-home points here at the beginning. Osteoarthritis is simply cartilage wear. It's a common problem. It can affect old and young people, especially people who've been very active and have had injuries. Second, the arthritis symptoms. Pain is common, and it's caused by the nerve endings in exposed bone and inflammation of the synovial lining. Stiffness is a common symptom as well, which can be due to excess lubricating fluid being present in the joint, which makes the joint feel tight. The synovial lining, if that gets inflamed, it gets thickened, and the joint will feel stiffer as a result. And when the cartilage surfaces wear away, they're no longer smooth, and the joint will feel stiffer when you try to move it. As a result, all these things cause impaired quality of life, less joy, more dependence on other people or assistive devices, often a sensation of being trapped because of the condition. Unfortunately, there's no cure for arthritis. There's no way to grow normal cartilage. So the treatments focus on slowing progression of the disease and reducing symptoms. Joint replacement is the final step in the pathway, and it's the most effective treatment for advanced arthritis. You can correct alignment problems, and the results are long-term excellent. So arthritis, again, is just wear and tear. And on the picture on the left, you see localized osteoarthritis involving the medial femoral condyle. And on the right, you see lesions in multiple places on the end of that femur. Up close in the operating room, this is how an osteoarthritic lesion can look if it's localized. This is bare exposed bone on the medial femoral condyle. On X-ray, we're focused on the joint space. So we're looking at the space between the femur and the tibia. If the joint space looks narrow on a weight-bearing X-ray, that means there's less cartilage there and there's arthritis. The lateral side in this case has a well-preserved joint space. On this X-ray, we still have joint space narrowing on the medial side, but we have this old tunnel from an anterior cruciate ligament reconstruction and hardware in place from that. So that's another arthritis appearance. And on this third one on the right, this patient has involvement in the outer side of their knee, and as a result, they're very knock-kneed. So 3 different pictures of the same sort of disease. The osteoarthritis can be mild, where the joint space is just a little bit narrow, not quite bone on bone. Or you might have a severe case where not only is the cartilage gone, but the bone is actually damaged, and in this case, the femur is sliding off the tibia. I often will liken a joint to a tire on the car. I tell people, well, your tire's getting thin or your tire's worn out. And patients will often ask me why some people's joints wear out more quickly than others. Why do some tires wear more quickly than others? Well, some have bad quality rubber. And in the case of a person, that might be the cartilage durability that you inherited. There's also damage to the rubber on the tire. If somebody gouged out a piece of the rubber on your tire, it's going to wear more quickly after that. So if you had an injury along the way, a significant sporting injury or whatever, that's going to lead to an arthritic joint earlier in your life. So we call that the driving habits of the driver. If you're a tennis player and you're pounding it on the hard courts for day in and day out for years and years, that's going to wear out your tire a little bit more quickly. If your leg is out of alignment, your knee is going to wear more quickly, just like having a wheel out of alignment on a car is going to cause the tire to wear more quickly. And if you're driving a car that's too large for the wheels, then that tire is going to wear out more quickly. So here's a U-Haul truck with nice wide tires that are going to last a long time. But if the U-Haul truck is this big and the tires are only this narrow, those tires are not going to last. The treatment algorithm for osteoarthritis from the American Academy of Orthopedic Surgeons and the and the Osteoarthritis Research Society International involves certain core treatments that's recommended for everybody. The first is education, which is what you're getting right now. The second is understanding of the role of diet and weight management in the prevention of osteoarthritis and the prevention of the progression of it. Land-based exercise is also important. Reduction in our sedentary behavior that we might have picked up during COVID, and that needs to be addressed. And strength training is also important. Moving forward to additional treatments, they're typically situation-based. Topical anti-inflammatories such as Voltaren gel can be really effective. Oral anti-inflammatories like Advil and Aleve that are not particularly selective are also quite helpful. Some patients will get upset stomachs with Aleve or Advil, and will recommend adding a proton pump inhibitor, one of the basically acid reducers that you might pick up in a grocery store like ranitidine or Zantac or cimetidine, etc. Those can help you tolerate your anti-inflammatories a little bit better. For patients who really have stomach problems with anti-inflammatories, selective COX-2 inhibitor type anti-inflammatories like Celebrex are super helpful, but that's a prescription medication. It's more expensive. From there, we go to intraarticular injections, such as steroids and others, which we'll cover in a little bit more detail in a minute. Often we'll recommend using canes or other assistive devices, and occasionally for wear on one side of the knee, we'll recommend unloader bracing. Let's walk through the injections right now. One I get asked about a lot is PRP, or platelet-rich plasma, which is a concentration of your platelets which are injected to accelerate the healing of injured tendons, ligaments, muscles, and joints. It really doesn't have much to offer in the setting of osteoarthritis, so we don't particularly use it for treating this condition. Steroid injections reduce inflammation, and as a result, they lessen the pain that's coming from the inflamed lining of the knee, from the synovitis. They also decrease synovial fluid production, which makes the knee less swollen as a result. They're not as good at resolving bone-on-bone pain, however. Improvement can go for a month or more, and the injections can be repeated every 3 to 4 months. Steroid injections are safe unless they're repeated many times. And following a steroid injection, surgery is contraindicated for 3 months because of an added risk of infection. There's a new longer-acting steroid medication called Zilretta that is now FDA approved and covered by Medicare. It is a commonly used steroid, triamcinolone, which has been embedded into a microsphere which gradually dissolves over a period of 3 months, giving you a lower level of anti-inflammatory effect, but over a longer period of time. Hyaluronic acid is common, and there are several versions. It was originally derived from rooster combs, but it's been synthesized, and there's several versions on the market, some allowing a single injection and some with 3 to 5 injections spaced a week apart. Hyaluronic acid is very effective for mild to moderate osteoarthritis, especially if you don't have much swelling. The advantages are that it has a safety record that's been outstanding over the 25 years it's been out. Improvement can occur for up to 6 months if it helps, and it is covered by Medicare. Our favorite version is called Gel 1, and it's actually sold right now by Zimmer Biomet. It's a cross-linked hyaluronic acid, which actually makes it much more stable and resistant to diffusion. It's a single injection option, and it has better mechanical properties than some of the other popular ones on the market, like Synvisc, which is shown here on the graph on the right. Another injection option, which is newer, I'd like to mention, and that's amniotic fluid. It's harvested by mothers who are having C-sections, and they consent to have this done. And there are several products that would be included under the umbrella of amniotic fluid, some of which include tissue. The amniotic fluid in general is quite rich in stem cells, growth factors, and anti-inflammatory agents. It's helpful for inflammation, tendon and ligament irritation, and moderate osteoarthritis. In fact, there's been some randomized controlled trials done, which have shown that 80% of patients are improved for up to 9 to 12 months following amniotic fluid injection. Unfortunately, it's not yet covered by insurance and runs about $1,500 through our office. Incidentally, if you have questions about injections, I would recommend having a conversation with Dr. Dave Mishra, who works in our office. He's actually a consultant working with the biotech firms that develop these products. He has wide experience with ultrasound-guided injections. Okay, moving on to the surgical treatment for knee osteoarthritis. We've got basically 3 options, which is a surgical realignment of the knee where you preserve the joint, and that's called an osteotomy. And we'll go into that in a little bit more detail. There's partial knee replacement, including medial unicompartmental replacements and patellofemoral replacements. And then there's total knee replacement. I also mentioned on this slide that arthroscopic treatment has a very limited role and should only be used to treat patients with primarily mechanical symptoms. So osteotomy. The goal of an osteotomy is to improve the knee alignment. It's taking that wheel that's out of alignment on the car and putting it in the correct alignment, unloading the worn side and shifting forces to the less worn side. For a bowed knee, typically the bone cut that I'll show you on another slide is made on the tibial side. For a knock knee patient, the correction is typically done on the femoral side. So I'm giving you an example here of the correction on the tibial side, so a high tibial osteotomy, which is used to correct a bowed knee. So first, this diagram shows the front of a knee, and you see there's a little red line, which is the bone cut that's made from the medial side, headed up slightly over to the lateral side. After the bone cut is made, then that space is opened, creating the correction. And then a bone graft is placed into that space and held in place with a plate and allowed to heal. These typically take about 8 weeks to heal, and you need to protect weight bearing during that time. But then you can go on and live your life, and you don't have to worry about beating up on your knees so much. So who should have one of these? A young active male is the ideal candidate because their bone quality is going to be better. Ideally, they need to have wear on the medial side only and a bowed limb. The ACL needs to be intact for these to work well. Patients under 60 are the best group. And for patients that have it, they can expect a 60% chance of avoiding a knee replacement for 10 years. So maybe that patient makes it to 65 or 70 before they have their first total knee. Okay, we're going to spend the rest of the time on knee replacement. What is a total knee replacement? Well, it's a resurfacing of the knee. all three of the joint surfaces, namely the medial side, the lateral side, and the front of the knee, we call that the patellofemoral joint. Those are replaced with metal caps, and a plastic insert acts as the artificial cartilage. What about a partial knee? Well, in a partial knee, only one of three compartments is resurfaced. In the case of a medial unicompartmental, we're only resurfacing the inner side of the knee. So here's a diagram showing a patient with only wear on the medial side. The lateral side is in great shape. The front of the knee, the patellofemoral articulation, is in beautiful shape, and the cruciate ligaments are intact. So this patient's a great candidate for a unicompartmental. So the bone cuts are made just on the medial side, and the implant goes just on the medial side, leaving the lateral side and the patellofemoral joint alone. The requirements for success of a unicompartmental include a well-preserved lateral and patellofemoral space, as I mentioned, an intact ACL, reasonable body weight, and avoidance of high-impact activities afterwards. There are a lot of advantages of medial unis. Less surgery means less pain, so the patients get over this operation more quickly. Because the ACL is preserved, the joint kinematics, how that knee moves, how you feel that knee is moving in space, is normal. The knee feels much closer to a normal knee than it does after a total knee, for example, where we take out the ACL. Medial unicompartmentals are actually quite long-lasting, and the results after 10 years are almost the same as a total knee. The other type of partial knee, which we do fairly commonly, actually I did 2 of them today, is a patellofemoral replacement. So this just resurfaces the front of the femur and the back of the patella, and for patients who have isolated wear, they definitely prefer it over a total knee. Here's a diagram showing wear just in the front of the knee, so the medial side and the lateral side are in good shape, and the back of the patella is worn. And this is what the implant looks like. Just resurfaces the front of the femur, and then the patellar piece is resurfaced with a piece of plastic, just like we do in a total knee replacement. There's a number of advantages to this operation. Again, less surgery, meaning less pain and a quicker recovery. And there are studies showing that after 1 year, patients who have isolated patellofemoral wear are more satisfied with a patellofemoral replacement than with a total knee replacement. Here's some X-ray examples just so you can see. Here's a patient viewed from the front with well-preserved medial joint space, well-preserved lateral joint space, but the patellofemoral joint is trashed. There's no cartilage on the outer side. In fact, the patella is subluxed off laterally. It's been maltracking all of her life. And here's the patellofemoral replacement that we did, I think on Monday of this week. The cap on the front of the femur and the patella tracking centrally in the groove. So it's just to summarize partial knees, about 15 to 20% are candidates for that. The results are excellent and patient satisfaction is quite high, higher than with a total knee replacement, although total knees can do quite well too. The durability is quite good over 10 to 20 years, but it does require more surgeon expertise in terms of selecting the right patient and carrying out the technical aspects of the procedure. So we'll spend the rest of the time on total knee replacement, and then we'll go to some case studies. Total knees have evolved. They started in the United States with Dr. John Insull in New York in 1970, and really not much changed in terms of the implants between 1970 and 2000, as well as the surgical technique. There were some improvements in the jigs to make the operation more consistent, but it was Dr. Luke Vaughn in Southern California who started to develop techniques to do a total knee through much less exposure. Then Alfred Tria back east and Tom Kuhn in 2002 worked with one of the implant companies to make the instruments much lower profile and facilitate the operation. And then I brought that to the West Coast in 2004. A total knee replacement is a reliable fix-all. When you have a knee that is worn out and it's crooked, a total knee corrects the alignment, resurfaces the knee, and gives you a long-lasting result. So it's hard to beat in those difficult cases. When nothing else will work, like this picture I showed you earlier with bone loss, that knee can be straightened out, bone grafted, and that patient go from being in a wheelchair to walking because of a total knee. What to expect after? Well, it's about a 12-week recovery period. The first few weeks you're much worse than you were before the surgery, but by the 3-month point, patients have returned to all their activities. My tennis players are starting to hit balls again. Walking, biking, and swimming are generally done comfortably. 80 to 90% of total knees are still working well after 20 years, and most will last over 30 years. Last year, over 1 million knee replacements were done in the United States, and that number goes up every year. What do we do differently here? Well, we use the less invasive surgical method that I mentioned earlier, starting in 2004. We're not flipping over the patella. That's the main difference. So if you don't have to twist that patella and flip it over, then that means that you can use a smaller skin incision and you can reduce the dissection of the quadricep muscle. If you do those things, then the knee flexion is going to return quicker because you have not traumatized the quadricep muscle as much during the surgery. What else do we do differently? Well, we've developed some rapid recovery protocols involving anesthesia and injections. We don't use general anesthesia at our facility. Instead, we employ adductor canal blocks, which is a low block of the femoral nerve, which gives you numbness over the front of your knee for about 8 hours, and spinal anesthesia. And then intraoperatively, we inject all around the knee joint with long-acting local anesthetics, some of which can last up to 3 days. We're quite efficient and we do a lot of cases, so we have a short operation duration. And all of those things lead to shorter hospital stays. Our clinical experience beginning in 2004 with the less invasive version, I've got nearly 10,000 knees that I've done since that time. Our average age 70, slightly more women than men, and you can see a wide weight range there. I looked at our results just for the last 6 months of 2020, which of course were affected by COVID, but just to show you the breakdown of the cases that we did. During that last 6 months, I did 198 total knees, only 9 medial unicompartmentals, and 13 patellofemorals. So it's really only more like 10% during that last 6 months of 2020. The average surgical time was 46 minutes. 100% of our patients were discharged home within 1 day. The total knees, 60% had same-day discharge, and the partials, the unicompartmentals and the patellofemorals, 100% went home the same day. The average flexion at 2 weeks was 113 degrees, and the average time to get rid of the cane was 7 days. Okay, so how about if we move on to some real case presentations? Hopefully you will find yourself in one of these scenarios. This first one is going to be really easy if you've been paying attention. We got a 71-year-old woman. She was a retired professional tennis player whose name you would recognize. She's completely healthy. She's had a prior ACL tear. She's 5'6" and 120 pounds. And here are her X-rays. Both the medial and lateral compartment are involved. She's got cysts that have formed in the bone. Her patellofemoral joint is completely destroyed, and you see that on this view down below. The patella is quite thin. It's ground away. So she's got 3 compartments, including the patella, and she's got an ACL tear. What's the answer for this woman? Of course, a total knee. There's no way to address all these problems without resurfacing all of the compartments. Okay, now we're going to get a little more difficult. This is case number 2. She's a little bit younger. She's not an athlete. She's got mild pain with walking that's been going on for some time, but she's much worse this week because she was helping her daughter move into another home and was moving boxes. Now her knee is swelling some. She's not had any prior knee surgery. She's 5'5" and she's 200 pounds. Here are her X-rays. She has preservation of the joint spaces, including the patella. She has a little bit of osteopenia as I look at this right now too, so she's got some osteoporosis that might need to be worked out. But this lady is an ideal candidate for an injection, and that's because she still has joint space. Her symptoms are worse recently, and she's got that swelling, which suggests there's some degree of synovitis. And when you have synovitis, that can change how the patient's doing. They can get worse or they can get better, and you can intervene with synovitis with an injection of steroids. So an ideal candidate for a steroid injection. Case number 3. Okay, here's a younger male, 55. He's a heavy worker. He's actually had a hip replacement before. That's a left total hip arthroplasty, which was a work-related problem. So he's got a job that's hard on his body. He has pain on the inner side of his knee when he loads it. He's not having mechanical symptoms. He doesn't have pain in the front of his knee, and he's not doing any sports currently. He'd actually had a prior arthroscopy, and I pulled the photos for those. The top of the tibia has bare bone. The end of the femur has some bare bone. His patella is in decent shape. And the lateral side, the outer side of the knee, is in very good shape. This is the lateral femoral condyle, nice and smooth. Good situation. So here's his X-rays. Loss of the medial joint space, and his patella is preserved. So he's 55, heavy worker. He's going to be hard on whatever we do. What do we do for this guy? Well, I don't want to put a joint replacement in a guy who's a laborer, so we sent him off for an osteotomy. So he had the bone cut done, bone graft put in, plate, 8 weeks later healed. He can go back to being a heavy worker and get his total knee replacement 10 or 15 years down the line. Okay, 4th case. Here's a younger athlete, 52 years old. She's a skier. She wants to return to skiing, which is odd because she tore her ACL skiing and had it reconstructed, and that failed. But she loves it, and she's completely healthy, 5'4", 115 pounds. Here's her X-rays. So she's worn out the inner side of her knee. You see the screws from the prior ACL reconstruction. Her patella is not great. Bone spurs, a little bit of narrowing. She's got large bone spurs in the back of the knee. So here we are, one major compartment involved, to a lesser degree the patella, and a failed ACL. She needs a total knee. So there's her total knee from Monday of this week. Okay, we're getting toward the end. Here's an older gentleman now. He's 89 years old. He's got a lot of medical problems, but they're actually stable. His medical doctor encouraged him to come and see me. He's losing his hearing. He's blind in one eye, and he was widowed, so he's actually living alone. He's got some family support, but he's living alone. His knee is really in the way of his life, and here's his X-rays. He's got that wear on the medial side like our osteotomy patient had, and his patella is in really good shape. But he's 89, he's got some medical issues. He may have a tougher time with the rehab. What's the choice? Well, I did a unicompartmental. We did a medial uni. He got over it well and was able to return to his life at his level of function, and he had a much easier rehab than he would have had if he had had a total knee replacement. Okay, one more case. This is our last one. This is a heavy-set attorney. He's a trial lawyer, if you know what I mean. And he's got pain on the medial side of his knee when he loads it. He's not having pain in the front of the knee, and he's not an athlete. 56, but 260 pounds. He's got a bit of a beer belly on him. Here's the medial side of the knee, and it's worn all the way through. His lateral side is good, and his patella looks pretty good. You might be thinking, oh, Dearborn's going to show us another medial uni or maybe an osteotomy. I thought this guy needed a total knee replacement just because he's a lawyer. And if something goes wrong, guess what? But he wasn't treated by me initially. He saw another surgeon who did do a medial uni. And quite frankly, it looks pretty good, the way it was done. The alignment looks good, so I can't argue with the technique. But 260 pounds, pounding around on this thing. 6 years later, his unicompartmental failed. Just the body weight allowed this implant to lift off, and the implant came loose. And then we had to revise it to a total knee replacement. Well, that's all I have for my presentation today. Maybe we can move to some questions.
Thank you. Is it safe to have an elective surgery such as a knee replacement during the COVID pandemic?
Pardon me while I get some water. That's a great question. We have been operating solidly during this pandemic, except for the 5 weeks in March and April where we were told we couldn't do any elective surgery. So we've been able to proceed safely by testing all of our patients 3 to 4 days for COVID. At this point, all of our staff have been vaccinated, so we're feeling better about things. But we've had, I showed you our data from the last 6 months of 2020. I did over 220 knee cases during that time. One thing also that helps is our building is quarantined away from the rest of the hospital. We have all private rooms, so you're not going to be exposed to any COVID patients while you're here in the hospital.
Okay. What could I do before surgery, such as exercise or lose weight, so the knee replacement would be more successful?
Oh, music to my ears. Prehab. I love it when patients prepare for surgery ahead of time. I would say getting a stationary bike would be a great option. If you can afford it, get a Peloton. Stationary bike is well tolerated, gives you your glute strength, your quad strength, as well as your cardio. And that's going to get you in better shape for surgery. And it will probably also help you lose a little bit of weight. And I would say also shifting diet and trying to focus on kind of a ketogenic type approach to diet would also be helpful leading up to surgery.
During normal activities, I have no knee pain. However, when I go for a hike and walk downhill for a prolonged period, I develop a strong pain just above the kneecap, which lasts a few days and makes it more difficult to walk downstairs. Is this a problem with the knee joint, muscles, or tissue damage? What can I do to strengthen my knees or correct the problem to avoid the pain?
Oh, it sounds like you're describing patellofemoral pain to a T. Typically, patellofemoral pain will hurt when you're doing descents, sometimes also going upstairs. And that's due to chondromalacia, which is softening of the cartilage on the back of the patella. It could even be worn, and that'll produce pain because there can be some exposed bone there. The treatment for chondromalacia patella, pardon me, involves improving patellar tracking. And physical therapy, especially focused on strengthening of the medial quad muscle, is the mainstay of treatment. Anti-inflammatories can also be helpful, but keeping the quad strong is your best bet.
Okay. Will I need physical therapy after surgery, and if so, how long?
Physical therapy is vital, especially after knee surgery. We use it a little bit less after hips, but with knees, we need to get the knee moving. So that first couple weeks, patients will have physical therapy at home, with a therapist coming to visit you in your home. And then for probably 4 to 6 weeks after a knee replacement, attendance of outpatient physical therapy in a PT clinic is vital to get the knee range of motion first, and then to get the knee strong again after the surgery.
Okay, and our last question, how old is too old for a knee replacement?
Oh, great question. Well, I just showed you an 89-year-old that had a medial uni, but we have knee replacement patients that we've done up into their 90s, actually even into their late 90s. I think I had 2 patients last week who were over 95. And so we really look at age more physiologically than chronologically. So I don't think that there's a particular age that's too old. And then on the young side, we have a patient who's in her early 20s that we did a knee replacement for. She'd been in a car accident and destroyed her knee due to that. So we have a fairly wide age range that we consider. If the patient's healthy and they're still competent, their brain's still working, and they're in their 90s, and they have some level of independence, we don't hesitate to recommend a knee replacement in that setting.
This concludes our program. Thank you, Dr. Dearborn, for your expertise. And thank you, viewers, for tuning in. The entire broadcast of today's event will be available on our Facebook page and YouTube.